Hello, we are Group 5 and our topic is Rheumatoid Arthritis, abbreviated as RA. I'm Shuwei Justin.
Hi, I am Jeffrey Chun Yet.
Hello everyone, I am Chun Jason.
Hi, I am Mingheng Henry.
I am Mingheng.
I am Alphas.
In this poster, we will introduce different aspects of RA, including its background, causes, pathologic mechanisms, signs and symptoms, as well as its development and its treatment and prevention.
So I will talk about the introduction of RA. So RA is an autoimmune disease that affects joints. So it means the immune system attacks the joints by mistake. So the joint may suffer from some inflammation. So Japanese and French is less likely to suffer from RA compared to Americans. And also women is likely to get RA than men. It's due to the sex hormones called estrogens, which only women will produce, however men won't. So aging problem may also increase the chance of getting RA.
Then I will talk about the cause of rheumatoid arthritis, RA. First, I would like to discuss about the genetic cause. When your body has some specific genetic component, you are more likely to get RA. There are two examples. The first example are the shared epitopes of MHC associated with the alleles within the HLA-DRB1 genes 4-5, and the second example is the long MHC, long HLA A alleles PTPN22R620W. Then I would like to talk about the environmental cause that will make people more likely to get the RA. Those environmental causes are smoking the cigarette, air pollution, use of alcohol, high birth rate, early life hygiene, and hence they have more chance to exposure to different types of antigen, use of oral contraceptive pills, and nulliparity. The last cause is the interaction of human gene to environment. When there is interaction between the smoking and the genetic risk inherited in the HLA-DRB1 and the PTPN22 genes, it is more likely to get the RA.
Part 3 is the pathologic mechanisms of RA, and before entering into the main content of this part, I will talk about the background of ACPA positive RA that we will focus on in this part. Actually, there are two subtypes of RA according to the presence or absence of ACPA, which is the anti-citrullinated protein antibodies. For your information, citrullination is the post-translational conversion of the amino acid arginine into the amino acid citrulline by an enzyme called APDs. And since the ACPA positive RA is the major subtype, and also it has a more aggressive clinical phenotype. So in this part, we will focus on ACPA positive RA, and we will divide its progression into several stages.
So good morning. So now I will focus on the first two stages of rheumatoid arthritis, which are namely the triggering stage and the maturation stage. The first stage of rheumatoid arthritis is the triggering stage. During the triggering stage, rheumatoid arthritis would be triggered by an interaction between the genetic factors and the environment. For instance, when a person has a certain gene that codes for an immune protein, like human leukocyte antigen DRB4, they might actually develop rheumatoid arthritis after exposing to environmental factors, like cigarette smoking or air pollutants. By exposing to these risk factors, autoantigens in our body will undergo citrullation, a process where the amino acid arginine in the protein is actually converted into citrulline. Possessing the susceptible gene like HLA-DRB4, antigen-presenting cells in our body cannot recognize the modified autoantigens as self. The antigens then get processed by the antigen-presenting cells and are carried to the lymph node. The antigen-presenting cells then activate CD4 helper cells, which then divide and differentiate B cells into plasma cells to produce autoantibodies, which is also known as anti-citrullinated protein antibodies in this case. These anti-citrullinated protein antibodies would in turn act against the autoantigens that has just been citrullinated. So this is the triggering stage. So now let's focus more on the maturation stage. During the maturation stage, more and more self-antigens were citrinated and are exposed to antigen-presenting cells. This causes numerous antigen-presenting cells to present their antigens to different MHC class II T cells, which then activate B cells into plasma cells, producing a wide range of anti-citrinated protein antibodies. The immune response that involves more and more T cells and autoantibodies against endogenous epitopes is also known as epitope spreading. And after epitope spreading, the titer of anti-citrinated protein antibodies increases a lot. So this is the end of the first two stages of rheumatoid arthritis.
The third stage of RA is the targeting stage, in which tissue damage will occur. To begin with, the ACPA can induce pain, bone loss, and most importantly, inflammation. As a result, the normal synovial compartment is infiltrated by leukocytes, while the synovial fluid is flooded with pro-inflammatory mediators, which interacts to produce an inflammatory cascade. The cascade is characterized by the fibroblast-like synoviocytes, abbreviated as FLS, and their interactions with the cells in the innate immune system, such as macrophage, monocytes, dendritic cells, and mast cells, as well as those cells in the adaptive immune system, such as T lymphocytes, which is responsible for the cell-mediated immunity, and the B cells, which is responsible for the humoral immunity. And these two immune systems and their interactions are very important, involved in the development of ACPA positive RA, and eventually it results in the failed resolution of inflammation, which is the chronic synovitis.
Fulminating stage is related to functional change. In this stage, it occurs hypoplastic synoviums, cartilage damage, and bone eruption. Hyperplastic synoviums results from FLS deficiency and the cartilage damage. FLS produce MMPs, which can facilitate the breakdown of the type 2 collagen networks as result in biochemical deficiency, and then articular cartilage does not have adequate capacity for regeneration on its own. Finally, apoptosis chondrocytes gradually disappear from the cartilage as the result of synovium cytokines, mainly IL-1 and 78 and reactive nitrogen intermediate. And next, the bone eruption. It causes induce of osteocyte and the suppression of the osteoblast. According to the conventional inflammatory theory, tumor necrosis factor alpha, IL-6, IL-1B, IL-17, and other inflammatory cytokines associated with RA may have pro-osteoclastogenic effective and inhibits bone formation in the right circumstances when they are activated by the right signal, such as RA and QL, and microphage colony stimulation factor. This encourages monocyte infiltration and osteoclast development when inflammation is present. Okay, there are two mechanisms for autoimmunity. The first pathway related to the development of immune complex and FX receptor mediates differentiation of osteoclast. The second is the development of anti-circulators vitamins antibody, which are produced against the most circulators proteins, making osteoclast the ideal antigen target for this antibody.
So for signs and symptoms in RA, the early signs of RA patients may be the inflammation of phalangeal joints, like swelling, pain, and also morning stiffness, in which the patient may feel this very stiff of their joint in the morning, like after waking up, and also the motion impairment. And for general symptoms that every patient may suffer, commonly may be discomfort, fatigue, loss of weight, and fever. Finally, the extra-articular involvement, which means not including the articular inflammation, but maybe other kind of sickness in other sites, maybe synovitis, which is the very common symptoms. And of course, there are many other involvement. I will just talk about synovitis. So in this diagram, it shows the inflamed synovium spreading across the joint surface. And besides of inflamed synovium, which is synovitis, there may also be the bone erosion. As you can see, this bone is eroded, and the cartilage in the middle is getting thinner and thinner. This can conclude for a joint affected by RA patients.
In this part, I will introduce multiple regions affected by rheumatoid arthritis, which does not only affect the joint. For example, a cytokine called interleukin-6 increases the production of hepcidin in the liver. Hepcidin is a protein that enters the circulation and blocks the iron absorption as the small intestine and may cause anemia in the patients. Also, in the heart and vessels, another cytokine, TNF-alpha, induces oxidative modification of low-density lipoproteins. This is an early event in the atherosclerosis and may cause other cardiovascular diseases. Moreover, other cytokines increases the production of reactive oxygen and nitrogen species. There are free radicals that inhibit muscle contraction and so may cause muscle weakness. The nerve can be affected as well. Inflammation in the joint may cause swelling, and this swelling will cause pressure and compress the median nerve at the wrist, and this is known as the carpal tunnel syndrome. In the next part, my partner will discuss the treatments.
Then I will talk about the treatment and prevention of rheumatoid arthritis. There are two main ways to treat it. The first way are the non-pharmacological therapy. In this type of therapy, we can intake more omega-3 fatty acid and fish oil to prevent RA. Furthermore, we can lose weight if we are obese. Lastly, if the RA is too severe and it damages our tendons and joint and causes severe pain, we should undergo the surgery to repair the tendons, joint to relieve the pain. The second way is pharmacological therapy. In this type of therapy, we will use the NSAID and glucocorticoid to relieve the symptoms such as the pain and inflammation. Moreover, DMARDs are used to slow down the progress of RA.
To conclude, we have introduced you to different aspects of rheumatoid arthritis, and this is the end of our presentation. Thank you.